portion. If you dilate, aggressively dilate to the normal portion, so it may make some damage in the vessel, so we accept this condition. Only this portion a little bit smaller compared with another portion, but if we think about the vessel damage, it might be acceptable. How do you think? No, you don't agree. We did the first dilate.
We take your point, we'll do it later, but let's go back to the left main. What do you think about the left main? Can you show the left main OCT? OCT of the left main. OCT of the left main. Okay. So the OCT of the left main and ostium of the LAD and circumflex.
Can you see the
This is the OCT of the LAD. You can see the old stent, intimal hyperplasia, which is not very severe. And come back to the left. This is the LAD, isn't it? This is the ostium of the LAD. This is the left main. What is the diameter stenosis? Diameter, can you tell us?
42%.
42% is the stenosis. And what is the minimal
minimal
area?
diameter is 1.6.
Minimal area is diameter 1.6. And what is the minimal area?
Area is 2.3. 2.3.
So minimal area is 2.3. Diameter is 1.62 minimal. And in some views, this is the only view where the left main is significant angiographically. Many views we miss it. So the question is whether to be treated or not.
Yeah, here is an just proximal orifice, LED, right? And also here is a bifurcation, and also some disease in the left main distal, right? And the left main is here, nearly. Hello.
This is the significant left main. And LAD ostium, how much is it?
We cannot hear anything. Can you hear me? Can you hear me?
L6, you can show the L6 ostium also. Hello?
Hello.
What this fellow is doing? Oh, yeah. Oh, we'll finish the year, then we'll do.
Yeah, but we miss to the dilate distal portion, right? Yeah, right. So 3 is too big in the distal, right? Yeah.
Hello?
Hello?
This one keeps swaying. No, keep running. No. Get and one more view where it is not very clear.
Hello? So how do you think about the landing portion? You try to put here, this might be the best position, right? Yeah, landing. Yeah, so 2.5, right? Here. Hello? You can sit, you can hear me? Okay, we're just discussing about OCT finding of the left main and ostium of the LAD, and I think left main is significant. This angiographically, in this view only it is significant. Other view doesn't look significant. In fact, you don't find in disease views. And we have also taken the OCT of the ostium of the circumflex. Can you show the ostium of the circumflex? Yep, and here is the ostium. We already have the OCT from distal CX to the left main. So the ostium of CX should be okay.
Ostium of the circumflex looks okay with the OCT, and you can see it very clearly here. So angiographically there is some haziness, but we are not sure. but it looks on the OCT clear. So the plan is the disease is from left main to LAD, and we plan to stent left main to LAD and protect the circumflex. That's the plan. And later on we'll do the RCA. So any other comment you want to have?
No.
Yeah.
Yep. Yeah, there are
the size of the left main is what is
3.5. 3.5.
Okay, so lumen to lumen is 3.5 and 3.87 is the mean diameter.
Mean diameter is,
Yeah.
yeah. Yeah, and I agree, but there are some discussion how to decide the stent size, media to media and lumen. We always add the quarter size bigger than the lumen area, so it's very similar to the media to media, right? Still, there are some discussion about the how to decide the stent size.
So what is the what should be, because if you are lumen to lumen is 3.87, media to media will be more. So what is the size you think we should take it? What do you, Ajay, what do you think we should take it? Okay.
So,
So what we do is we take a 3.5 stent and stent it and then dilate with 4 millimeter balloon near the left main. Is it okay? And then do the OCT and check. Okay. So we'll take a 3.5 and why do you want 4.5? Any specific formula, like, you know, OCT, if you see 3.87, you have to add something, or just your add 0.5 or something like that? 4.6. Yeah. Yeah, fine. We have the IBS here, but you no. Okay. So we'll go ahead and change to 3.5 and first dilate it 4 or 4.5 and then take the OCT.
18.
Yeah, fine. Yeah, fine. Yeah. Good. Direct.
was angina for last 1 year. Done outside, and the angiogram actually showed severe left main bifurcation disease. So there was initially advised surgery, but then he came to me. Then I said we could consider angioplasty. If you really see I'll show you the angiogram. The syntax score is only 14 because left main disease alone doesn't really give you very big syntax scores if you really think about it. So this is what the case is. If you see the angiogram, the aleocranial view shows severe disease near the left main bifurcation. The ostium looks okay here. Next, please. So again, some disease near the bifurcation. The entire left main looks a little narrower. Go ahead, please. Go ahead. Caudal view actually shows the left main division area, which is narrow, and probably the circumflex ostium. I'll show you in an enlarged view now. Next. So yeah, you can see that the ostium of the circumflex actually has a dent on the carinal side. So there is disease at the ostium of the circumflex, left main, and maybe the mouth of LAD. So this is classical left main bifurcation disease. The distal vessels are okay, so that's a good thing. Next. Next. Okay, go ahead. Nothing much. Can we see the right now? Okay. So right is average size vessel. Some moderate long segment disease in the proximal part. Well, if need be, it can also be done. So I think this is pretty straightforward. What would you think from the panel? What should be done for a case like this? If you have any. Yeah, correct. So, correct. So this is a pretty standard left main case, I would think. So can we just see the angiograms that we have just done now? Okay. So if we can, so from the beginning, the first one, please. Okay. So this is the angiogram that we have just done. So it shows a long left main, looks a little narrower all through. Go on, please, and the division there. Next, next, next forward, please. Okay, further. So that's the cranial view. Try to see the LAD looks okay distally. Next. Onwards, please. I need a, yeah, okay. So this is the AP caudal. Again, it shows the dent on the circumflex ostium. That's what I wanted to see. So the plan was now, you see, I actually strongly believe doing left main disease only with imaging. I think you would agree with me. So we have done we did a IVUS actually to size the vessels and all, because we had both OCT and IVUS, but I thought that for sizing the vessels, and maybe IVUS is better, especially in the left main and even otherwise. So because here sizing and stent going by the size of the vessel is very important in the long-term outcomes. So we have done a basal IVUS. I will just show you the IVUS run if it's okay. Can you show us the IVUS run, please? And that will tell us where exactly the disease. Yeah, can you see the IVUS, please? Can you show the IVUS? Okay. So that's the withdrawal from the circumflex. So first we did it from the, so there is some disease that is coming at about 9 o'clock position, and then as we get closer to the left main, there's more disease there. and then, so certainly you see all disease all round in the circumflex. The size of the vessel is about at least 3.5 as I see here. 4. And that's the LED coming in, and that's the plaque at the mouth of the circumflex. Can you see? That's the plaque at the mouth of the circumflex, that eccentric plaque. So that's very important. And then in the left main, distal left main has disease. A lot of plaque in the distal left main. This vessel looks about 4 mm here. And if you can show me that is the ostium of the circumflex which has been marked. So which shows disease eccentric disease at the mouth of circumflex. And that's the LED wire on the other side. If we can see the withdrawal from the left, from the LED. So if we see from there, we'll see the ostium of the LED. The purpose of this is to size the ostium of LED, size the ostium of circumflex, size the left main, and then plan your stent sizes. And once we've, so that's the left side coming up. Sorry, the LED coming up. So that's the Mickey Mouse septal. And then, so disease at near the mouth of the LED system. There is a eccentric plaque. And that's the circumflex wire coming in. And there is disease in the left main right beyond once it joins, the circumflex joins the LED. And again, and proximally somehow it looks much better. Well, I angiographically thought it might be having more disease, but it looks much better, looks quite big there. So maybe we may not have to put the stent till the ostium. That's what I think after having seen this. So now I have to get you live back into, can we just see where we are? So what we have done, can we move forward please? Can we move forward on the angiogram? There was a wiring angiogram. There was a wiring angiogram. Can we move forward? Just forward. Abhi ye to piche chala gaya. Okay, next please. Next. Now, no, go back please. Go back please. Run this fluoro. Now this is a very small tip maybe for the younger guys. It, you know, I had put the wire in the LED. I was trying to wire the circumflex. I showed you that the ostium of the circumflex had disease. And now you see this is not going. So the dictum is when you have these bifurcations, you should wire the difficult vessel first. So the circumflex had a bigger angle. So what you will see that we pull back the wire of the LED, put it into the circumflex, it goes one go, and after that the LED wire will also go. So this is just a small tip which I could catch, so I thought I'll show that. Next. This is for the young interventionist. Forward, please. So, go on, please. Come to the last angio, where we are now. So, those the IVUS withdrawals. Come to the last angio, please. Okay. So, that is where I am right now. I'll show you where I am. So, I have done the IVUS, and I have done some ballooning of both the ostia with a 3-0. Incidentally, I used a cutting balloon, which I thought gives you less of dissections. So that's where I am. So now I think I'll show you we'll get on to the stenting. So what size stent do you think we should do? And we'll do two stent strategy, I think. That's what I have decided. What do you think? 2 stent strategy or 1 stent strategy?
Which one first?
I think I'll take, let us take a 3.5. Actually, I always do radial, but incidentally in this patient, when the cart was done outside, I could not get the radial. So I had to do femoral, but otherwise I would always do radial, and I would do 6 French in radial, no problem. We could also put 7 with the ultrasound sizing of the vessel, and now we have a slender sheath from Terumo which we use where the external diameter is 6 French and internal lumen is 7 French. So you can do it. But because I didn't have the radial here, So I had to do femoral, and so now we are doing femoral, and that's the situation. 3.5, I think we need a little longer one. 18. 3.5, 18. Well, JL, I find I like the EBU much better. JL, you know, that last curve, that 90 degrees, that 1 centimeter tip, sometimes it makes things more difficult. We have got used to the EBU now, and I think EBU is much better. That's what I feel. Come on. Yeah. Yeah. That's correct. And the other thing which I would say, for left main, a lot of people think that you might use a side hole guide and all that. I don't really advocate that, and I feel a regular guide is much better, because side hole guide doesn't give you good pictures. And getting good pictures is equally important when you are doing such cases. So I don't take side hole guides in the left main. You can always ping pong come in and out of the ostium. Well, I am, you see now, once I am doing a committed 2-stent strategy, my first stent will always be on the side branch. Please hold on. Tum actively nahi karo. Please hold on. Sorry. My first stent would be on the side branch, and that's the principle we follow. Always, if you do two-stent strategy, then side branch stent first, and then the main branch, and it will be usually a mini crush. And what I usually do is a modified decay crush, not really two kissing. We will crush it with a balloon and then do the second stent, and then yeah. Balloon. Which strategy, sorry? Single stent.
The side branch is big.
No, but the side branch lesion was quite significant, and you know, it's a big vessel. I don't really want to take a chance. And then ending up, it is always better to have an elective two-stent than to do the side branch stent after the main branch. Test, please. Test. Sorry, just hold on. Just hold on. Test. Yeah. Injury. Yeah, that's a bigger problem. Angio, please. I think that should be fine. Dikhao mere ko. Just leave it. I need a balloon on the side. Give me a 30. Give me a 30. Wait, why is identified?
This is highlighting.
Okay. This is 3.5. Which is 3.5? 3.5. 3.5. यार ये confusion है. इसको इसमें से हटाओ. Remove this from this. Remove this. Is it okay? Fix the wire, please. Fix this wire, please. Fix the wire, please. Okay. Okay. Just a sec, please. Okay. Angio, please, come on. I think I need to push this stent slightly. Okay, come on, where is it? This is the stent?
Yep.
Okay. Come on, dribble. So that's the stent. So that's the stent. I have a balloon on the side to crush this. And usually the crush will be a very small segment if I'm not wrong. Yeah. Identify the wire. So this. Which is the wire? Yes, you're catching the right points, huh? Come on. Angio, please. Okay, so that's fine. Let's see how the circumflex looks. Circumflex looks okay. All right. So now what I need to do is, I think I'll have a 3.5 stent in the LAD also, extending into the left main. And we will then post-dilate with a 4 for the left main. I think that's what, is that okay? And we probably need a little, well, what was actually the distal LAD is 3.5. So, and you know, because I can see some disease little beyond also, so maybe I'll have a longer stent, so I don't want it to be too oversized. So I think I'll use a 3.5, yeah, 3.5, 28. 3.5, 28. Angio, please, one more. Ek angio karo. Yeah, 3.5, 28, I think. Let's do that. Yeah, so I'm using a Zions 3.5, 28. So let's see, and then we will post-dilate it to 4 in the left main or the proximal ostial part of the LAD. So that's, and then I'm going to recross. Yes. Then I'm going to recross. I usually recross with a third wire. So we have some time. So, test please. Angio. Test please. Angio please, come on. I think this looks okay to me. Is that okay, Lai? Oh yes, perfect. That's, maybe I can do it till the ostium. That's not an issue. Test. Kahan hai? Test please. Actually, this aleocranial is the best view for ostium. It shows you the best. Angio, please. You see, you get such a beautiful picture there. It's fine. Yeah, so I have just put it right from the ostium. So that's, yeah, the circumflex wire is